Hospital from 1996 to 2016 and in Van Halen Hospital in Kodaikanal up to 23. So he's a mentor, facilitator in CMC Vellore.
Thank you. Good morning, everyone. I thank the organizers of AFPI for giving me this opportunity to talk about navigating through diagnostic uncertainty. I think I also thank Dr. Anbarasi for setting the stage as a primary care physician, how we get involved into the art of consultation, being patient-centered consultation. So we all know that in this era of advanced technologies in investigations, treatment, and so on, as a primary care physician and in a resource-poor setting, you definitely face diagnostic uncertainty, where you need this skill of clinical reasoning. When a patient comes to us, we know the signs and we take a detailed history taking. As we heard, we do a 3-stage assessment by history taking, where it involves clinical, individual, and contextual assessment. And then we narrow down to a differential diagnosis. We do investigations relevant to the context. And with the reports, we review the patient, and also with past medical records of the patient, as well as from the relevant data. When a patient comes with a similar situation, what do I do? So we come to a definitive diagnosis, and we do a targeted management plan. So while doing so, what are the components involved? We have a fast, intuitive thinking. Could it be this? And then we also do an analytical thinking. Can this be a factor? Could this be a differential diagnosis? Yes, I am recognizing a pattern in this patient. So we recognize a pattern. Then we apply our knowledge, the scientific knowledge, evidence-based medicine. And then we also look at the probabilities. Probably this is my diagnosis. A patient coming with splenomegaly, if we work in an area where it's endemic for malaria, and we worked in a place with visceral leishmaniasis. This was in Jharkhand. So few set of things would go in my mind. And what are these? These are the core components which are essential for our clinical competency in having arriving at a clinical reasoning. So there are so many factors involved in this, and when you look at it, it is a difficult ball game, and at times it's like a jigsaw puzzle where you try to solve what could be the clinical problem in this patient. Could this be related to his context? Could this be related to his occupation? So we try to identify and put the pieces together in the right place, which is a part of our clinical reasoning. Let me take you through few examples. Say like a child coming with febrile fits, or a child with fever and irritability. Could it be meningitis? Or could it be, so it depends upon the context. So this child has been ill for some time. The child has been losing weight. Could it be TB meningitis? Or in an acute setting, you would think of encephalitis. An old elderly patient coming with shortness of breath on examination, on exertion, who is overweight, he's a smoker, and having cardiac risk factors. So these things go in your mind. Could it be a cardiac failure or a COPD or a deconditioning? Or when it comes to therapeutic uncertainty, an elderly patient with heart failure, CKD, Parkinson's, already the patient is on number of medications and his function is declining. So you have an uncertainty. Should I start a new drug, or should I reduce a drug could this cause a drug interaction? So these are some things. And coming to prognosis, a patient with a new presentation of depression with suicidal thoughts, is there any increased risk of suicide? Because antidepressant is not just an answer. So the drug I give, whether it can induce suicidal tendencies. Coming to investigational uncertainty, a patient with unintentional weight loss, fatigue, no other specific signs and symptoms. What test can be useful in diagnosing the underlying disease? So when we think of clinical reasoning, there are different domains in it. So we have the clinical reasoning concepts. Then when we do a history taking, it is not just a history taking at random. Okay, I take a relevant history to the situation of the patient, to the condition. So even our history taking and physical examination is focused. It's evidence-based. And then we choose, it is not a battery of investigations. So you may think, okay, probably this is my clinical diagnosis. I would like to confirm it by one or two investigations. Then writing a list of investigations, so something I will get out of this, so I can make a diagnosis. Not that way. So you are also focused where you use your clinical reasoning. Problem, so you identify the problem and what are the therapeutic options. Say like in the market, you may get teniglyptin, one tablet, you can get it for 4 rupees, you can get it for 25 rupees also. Can my patient afford this drug? In case of chronic diseases, for compliance, you need to know the costs. And then shared decision making. This is something as family physicians we all need to be practicing. It is not me as the clinician taking the final diagnosis and giving the treatment, but talking to the patient about the diagnosis, what are the treatment options available, which would be easier for you. I may think the patient may need to go for a CT scan. The patient may not have money. So given the options, what medications you take, and then when can you go? So it depends upon the condition. So it's used in all patient encounters from simple to complex presentation, and we gain increasing attention within medical education. Say like problem-oriented teaching is something which is very relevant for our practice. As a medical student, I may know everything about acute fever. I may be able to talk about, okay, if you ask me about pneumonia, typhoid, I will be able to talk. But when a patient comes to me, how do I approach acute fevers? How do I approach a patient with chronic cough? This is important, having a problem-based approach. So what are the educational strategies to promote clinical diagnostic reasoning? We can see it through the Bowen's framework. It is not only for the students, it is also for us as family physicians, as practitioners, as we all know, as doctors and clinicians. It's a lifelong learning. So what are the strategies planned in Bowen's framework? It is data gathering by history taking, physical examination, highlighting the key features. So you come to a problem representation, and then you search for the illness scripts. What does it mean? So we look at the data. Okay, in my area, in the last 10 years, this was during monsoon time, it was malaria, or post-monsoon, there has been a surge in patients with typhoid. So that way you also reflect back on the data available, or even about antibiotic sensitivity. You apply the knowledge from the illness scripts, that's the data previously generated, to the current patient. And you also sort out the data, apply your knowledge, and then you narrow down your differential diagnosis. As a medical student, as a postgraduate student, when I was learning in Odanjatram, our teacher, Dr. Raj Kumar, when we write an investigation, he would like to know why I want to have that particular investigation. So when you write an investigation or even a medication, whether it is relevant, whether it is needed. Let me add one more vitamin, let me add one PPI to the prescription. It's not the way to do it, but with clinical reasoning for every test we do and every drug we write. In Miller's pyramid of assessing clinical competence, as we go through medical education, be it a student or a practitioner, there are some cognitive skills involved where you do the fact gathering, interpretation, and application. And when it comes to behavior, we demonstrate our learning and performance integrated into practice. So from a medical student, as you progress in your professional career, you become an expert by doing all these things, what I know, how I know and apply this knowledge, and how do I interpret it in my clinical screening of the patient and performing into practice. So all of us need to continue to have this in our professional practicing. So there are some strategies which are suggested to navigate through uncertainty. One is designing the curriculum. It is like we know all the basic and clinical sciences as a practitioner, but then we also need to understand the complexities of healthcare delivery. So it is not only I know the investigations, I know the medicines, but what are the other indirect determinants of health which are involved? And so I need to know all these different type of uncertainty and responses early in the training. Comprehensive history taking by medical students. It's not just about a complaint of fever alone. What can be the other possibilities? It processes to enable the person to experience the role of a doctor. Dr. Anbarashi mentioned about 3-stage assessment, not just doing the clinical history taking, but going in, digging deep into the individual's problems. Can it be because of his alcoholism? Can it be because of the work pressure? Coming to the contextual assessment, can it be due to the family environment, or could it be due to his occupation? So going beyond the clinical scenario, using the golden minute, and to learn how to express empathy. In post-COVID times, we are all used to non-touch practice, not touching the patient. I'm sad to see many clinicians not even touching patients, and in some centers, they don't even allow the patient to sit in a stool. So wherever it's appropriate, touching the patient, leaning forwards, she was talking about linking, liaising. So as a practitioner, we need to express empathy. So only when we go into a 3-stage assessment, I will be able to know the patient as a person, as a whole person, what is he undergoing in his life, as a person, as a family, and what are the factors in the society. So when we know this, we will be able to express empathy. And when you express empathy, even a patient who is seeing you for the first time, I have seen it in my experience that people break into tears, and as if they know me for a long time, the entire story of the life comes out. So as family physicians, let's be patient-centered, family-centered, as well as community-oriented practice where we get a better history and make more accurate diagnosis. Thorough physical examination. If I don't touch a patient, how would I do general examination? How would I do a systemic examination? So learning to approach the patient with respect. I knew that when I put my stethoscope during my first clinical year, I had a feeling I was on the top of the globe, as if I am standing in a pedestal and patient is somewhere else. So treating the person as myself. I can be a doctor, but when I am stuck on the road with my car punctured, I need a person to fix it. So I may be a doctor to a patient, but I am also a human being. The patient is also a human being. So getting down to their level with respect to do target physical examination, just not at random. I had gone to a pulmonologist, and I was very sad to know that though he knows me as a family physician, he didn't even auscultate me. And I have seen doctors putting the diaphragm on the patient's chest without the earpiece on the ear. So do we do a real thorough physical examination? Because when we do it, that fosters confidence on you as a clinician, as a family physician. Mastering peer-to-peer, mastering personal communication, interpersonal communication. So that is when we say, when I have a clear plan, it is not just to myself writing the lab slips or writing the tablets. Okay, these are your problems. So probably these are the things I am thinking of. So we may need to do few tests. So come after your investigation. So when we clearly mention, so it is not, let's not define patient as a case. Case number, next case. Sister, can you send the next case? Can you go to number 48? It's not 48 or 58. Can you go to the lab, which is number 48? So the patient will understand what I am talking about, not using medical jargons. So you have a shared decision making, which builds the trust between you and the patient. Okay, my doctor is really concerned about me. Let me talk about my problems. He will be able to give me a solution. Peer-to-peer learning. This is something what we are doing now. We are collaborating with one another. So we teach and learn together. So we also learn how to handle the discomfort caused by uncertainty. So when I have a problem, I talk to my colleague and find out, or a specialist who is a friend of mine whom I know, okay, what can I do in this situation? Reflective journaling. This helps us process various uncertainties and how they can be solved. So when we attend a class, we take notes saying, okay, in family medicine, we have this reflective logbook. So after every session, the student is to write a reflective logbook. Okay, in this session, what have I learned newly? What will I be able to apply in my practice? That also helps us build our clinical reasoning. Mentorship or shadowing senior practitioners. This is what we do. Say, even I'm qualified as a family physician, but when I need to have a skill, so I work under a specialist for a period of time to acquire that skill. Because as family physicians, we have a wider spectrum of things to see, from pediatrics to geriatrics, from cradle to grave, and a wide spectrum of illnesses. So I cannot be a master of everything. So wherever I'm working, when I need a skill, I equip myself into that by mentorship program. Let me finish with the clinical vignette. A 45-year-old Sankar comes to a clinic with new onset chest pain that occurs during exertion and resolves with rest in the last 1 week. His vitals are stable, ECG is normal. He is a smoker. No other comorbidities. What would be our differential diagnosis? So some problems run in our mind. Could it be a musculoskeletal pain? Could it be an acid reflux? Or is it something like an underlying coronary artery disease? So there are some things which are more common, benign and non-life-threatening. At the same time, there could be something which is less common but more serious. So what is the diagnostic uncertainty I face here? Normal ECG does not rule out ischemic heart disease, especially since he's a smoker. If missed, he could end up with an MI. He needs a TMT or other cardiac workup to be done to rule out CAD. As a family physician, how do I manage him? So I check the family history, whether there's any early cardiac death, how about his occupation and lifestyle, whether he's into a lot of stress, what about his sleep pattern and diet. tests to rule out diabetes, hypertension, dyslipidemia, assess the risk factors for atherosclerosis. What is the communication challenge in dealing with such a patient? So here is where we have our challenge as a family physician. Reassuring him that it's likely to be harmless problem while explaining the possibility of a serious underlying heart disease, probably. Convincing him to get tested, motivating him to quit smoking. Yes, I would like to conclude with this application in a resource-poor setting. Say we lived in a place in Jharkhand, in a jungle where we didn't have electricity. Why do I say this? Because it was that remote. So we worked among a tribal community, and these are the village ambulances till today, how they transport a patient from the hilltop to the plains and then take a public transport. So we did primary care and secondary care. So being in a jungle, we had limited lab facilities. Patients were economically poor, and we didn't have any referral facilities in the neighboring 100 to 150 kilometers. And the tribal population living in a remote hill who have not been exposed to the outer world, they would say, whatever possible, you do it, or we will take back the patient home. And in such situation, and where diseases like malaria, tuberculosis, Kala Azar, you can see tuberculosis of any form which is described in the textbook. The girl in the middle shows splenomegaly, where malaria and visceral leishmaniasis were rampant, and 90% of the children were suffering with tuberculosis. So mortality was very high. Missing the diagnosis could lead to death of a patient. Referral was not at all possible. Therefore, the navigation through diagnostic uncertainty was a daily experience in our clinical practice. Clinical reasoning had to be applied diligently to make the best use of available resources. So I hope and pray that all of us as primary care physicians working in different corners of this country would continue to do this clinical reasoning to navigate through uncertain situations and apply the strategies, teach a younger generation that we will be able to be better family physicians. Thank you so much.